I'm Dr. BOJANA Weatherly, and I'm excited to bring you these conversations with Dr. Mayoni Gooneratne. She is a women's health expert from the UK. In this second episode, we're going to be talking more about the later stages of perimenopause as well as menopause. What are the common symptoms involved in these stages and how to address them with evidence-based modalities? I know that both Dr. Mayoni and I can agree that there are many, many more topics and deep dives and studies that we wanted to share with you that we did not get to during this time. I hope that we will be able to do so during future episodes, including more information on supplemental supports, other pharmaceutical supports, as well as other integrative medicine modalities. I do hope you enjoy this conversation, and thank you for listening. So when it comes to the WHI, there have been some misconceptions regarding how hormone replacement therapy affects women. And as a result of that, for 2 decades or more, many women have been denied HRT. One of the statistics that I read was that HRT use dropped off by 70% after this Women's Health Initiative study came out. Can you tell me a little bit more about how this factors in your practice? And certainly there have been more studies that came out since. There are many confounding factors that changed our interpretation of some of those study results, including the age at which women start hormone replacement therapy, the type of hormones used, the route of administration, the dosing. There are many different layers to that. So tell me a little bit about your approach and generally how you counsel patients when it comes to hormone replacement therapy.
Great. Yes, I think it was a landmark study. I think it's easy to villainize research, but I think we always have to learn from it. We always have to learn. We can't kind of sit there and go, oh my God, that was a load of rubbish. I think even if it was not the best conducted study, we've got to evaluate it for what it was worth. And like you say, it actually raised the importance of, I think, number one, more research in women's health. It talked, it was, just to clarify, it was one of the largest studies that's ever been carried out with women with, there were something like, I think almost 70,000 women were enrolled in these studies over quite a long period of time. And the thing was, they used different women, and they essentially were looking at the impact of hormone replacement therapy on women. Now, that was literally as broad as the criteria was, and so therefore, we've just talked about a few of the HRTs available to women. There are several, and I think it was a mixture of synthetic hormones. It was the way, like you say, it was delivered. These were given orally mostly in women, and we now know that actually using topical administration of estrogen is going to give a much better outcome for women in terms of the risks of cardiovascular disease and cancers, and also using a progestin versus a progesterone. A micronized progesterone is much better for women because it's the way it's metabolized and then utilized by our liver and our body is much more effective. And also, as a byproduct of that, actually using it orally is much better for sleep symptoms specifically. But this study used a mixture of delivery mechanisms as well. And it started HRT in women who normally would never have been given HRT. So they were already beyond the point of it being a safe time point or age for delivery of HRT. And as a result, the kind of analogy I always use with my patients is it's a bit like having your beautiful sports car that's been sitting in the garage for slightly too long, and then you literally put some petrol in and you take it out onto the highway for a spin. It's going to have problems. And that is what happens when you start using HRT Usually we say 10 years after that point of having had your last period. So remember, the definition of the menopause is it's 12 months of having no menstrual cycle, no menses, no bleeding. And so up to 10 years for most practitioners, I'd say, is when you'd feel it was okay to start HRT after that. Beyond that point, we start to get into that territory of it being a bit of a, you're starting up that beautiful sports car that's a bit kind of unused and a bit unloved. So it's probably better to not, and it's probably better to support your body with other methods. And, to my mind, it's going to be talking about your bone health, looking at your brain health and your cardiovascular health. Those are the three kind of important organs that we know we really need to protect and maintain into our 60s, 70s, 80s. These are the ones that are linked with all the longevity kind of conversations that people have. I think also, to go back to how I talk with my patients, I think the generation of women that are coming to see me now have probably not been as blighted by the WHI study as the women before that. I think the women who are now truly menopausal are the ones I worry about the most. They're the ones that, if I do a workshop or I'm talking to them, or, they will sort of say, oh my God, but HRT is really dangerous, isn't it? Isn't it really bad? And there is still a lot of work there to be done. And as a result, unfortunately, their GPs also thought that HRT was terrible and they missed that window. Now, I don't want women listening to this who kind of think, oh my God, I missed a window, that's it, I'm going to have XYZ disease. Absolutely not. But you need to work hard to optimize those organs that may not have benefited from HRT, maybe 10 years ago. And that's fine. Like there's lots you can do, and you mustn't sit there, like I say, panicking, but you want to be thinking about muscle-based activity. Really working on Pilates is specifically very well looked at in correlation with things like osteoporosis and osteopenia, because you are creating tension in muscle, which is attached to the bone. And we know that they have this lovely symbiosis. They talk to each other. So the more you're pulling on the bone with the muscle, you're actually then encouraging bone mineralization. You're encouraging it to be really strong. If muscle is not used, then unfortunately the bone that's supporting that muscle starts to lose its mineralization, the calcium and phosphates, etc., that are making up the structure. So you start to see an increase in risk of fractures, which we know is a really high index of disease and ongoing problems as women get older into their 70s and 80s. And it's the highest cause of mortality in women over 80. So, without being too morbid, it's like there's stuff we can do now. So don't feel like it's game over. So really working on your bone and muscle health.
Exactly. And really to stress, you alluded to this before, but really to stress that even for women who are going on hormone replacement therapy now and are on verge of menopause, it's important to stress that one does not replace the other, right? So if you are on hormone replacement therapy, while that might provide benefits with respect to fracture risk and with respect to bone density, it's certainly not sufficient to counter the fact that we are naturally predisposed to sarcopenia at later ages in our life, and we still need to work hard for it, to the extent that we can. But it's important to stress that, like you said, it's not all or nothing, and it's not just one or the other. It's really combined modalities that we want to use. And in that, you mentioned something earlier about protein intake. And in my patient population, when it comes to doing an analysis of macronutrient intake, we see this all the time under consumption of protein. It's just the macronutrient that's the hardest to get in. It's difficult enough for people who are consuming animal products, but then especially for patients who are more plant-based or people that are exclusively vegetarian or vegan, it can be a real challenge. But I want to stress, it is possible. So, for anybody listening, if you're having trouble hitting your goals or you're not sure what your goals are, talk to a nutritionist, have a session with a registered dietitian or licensed nutritionist, and then try to work within, okay, what are the foods that are within my scope of what I eat, what I'm willing to consume, and then how do I get to that goal? Because if you're not providing your body with a fuel, you're still going to lose out on that opportunity to build muscle. And as you said, it's such a metabolically active organ that when those estrogen levels drop, and when unfortunately we're seeing less metabolic flexibility, as you mentioned, more glucose intolerance, higher insulin levels, where insulin is important to store our glucose. And what we see as time goes on, and certainly with family history and other risk factors, is that those insulin levels rise. And there's a way to check this on labs as well. We're not really going to talk too much about labs here, but certainly in the future we might. But it's really something that's important to discuss with your provider as well, with respect to how am I doing metabolically? How are my blood glucose levels? Am I insulin resistant? Because again, that might inform the plan that you may want to take when it comes to nutrition, when it comes to exercise, and really having that metabolic assessment to see where you are. And one of the things that we use often in our practice when people are willing to and interested in doing that are continuous glucose monitors. I've certainly found that when I've used one, it's been helpful for me to better understand how certain foods that can be healthy, like tropical fruits, for instance, how my body absolutely does not tolerate it if I'm not eating it with a protein, with high fiber, and exercising right after. Like, it's just not something that I can have if I want to avoid a glucose spike. And those glucose spikes, of course, can be, in some ways can be physiologic. Of course, if we're doing certain kinds of exercise, our body is going to recruit that glucose because we need to use it with certain foods, but that's something we want to minimize because, again, there's been an association with certain chronic disease progression, cancers, and so on. So that kind of gives us that real-time information. And oftentimes, my patients who have, a so to speak, clean diet or not eating anything processed, whether it may be about the quantity or maybe not combining those carbs with protein, with fiber, with healthy fats in a balanced way, they might see those spikes and say, okay, I need to make a change. My body is not reacting well to this.
Sure. Yes, I agree. I love my monitor, and I've just come to the end of another little run and I'm missing it because it just gives me such real-time data. And I think my insight was actually oat milk. And I think for many women it does cause spikes, but for me, I was just spiking like I'd eaten a Snickers bar. It was 12, like it was crazy. Another interesting spike that one of my patients reported, and this might be interesting for your listeners, is actually those really very strongly perfumed fruity shower gels. And she was spiking at sort of 7:30 for 2 or 3 mornings in a row, and she just could not, she hadn't eaten. She'd literally got into the shower, and she worked out it was a fruity shower gel. So she was absorbing whatever stuff was in it, and I think this is the beauty of wearables. And I don't know, we've got time to talk about wearables today, but, wearables are powerful. I was not skeptical, but I was worried that patients would become too data driven and too introspective. But actually, what it's done is it's done a lot of the groundwork for me and my team, because actually women are kind of going, hang on, this is like, what do I need to do? What do I need to do? And, it brings out that kind of gaming, sort of gamifies their health slightly, which is really powerful. We use interestingly, biofeedback was a very well used technique when I was doing my research into fecal incontinence. So it's ironic it's come back into my world, but, we use biofeedback to help women to retrain their pelvic floor to good effect, because actually having that direct mind fit body connection really wires those pathways in our brain together. That's that neuroplasticity element. And so it's an absolute no-brainer to then use it for Aura rings or any kind of I love it for HRV data and sleep data and blood sugar data. I think those are three really useful pieces for women to help kind of navigate their health and optimize things.
I agree with you completely. And it's so interesting. I had a similar view of, are the wearables going to cause us to either hyper focus on minute to minute or 5 to 5 minute data segments? Or on the flip side, are they going to disconnect us from our own feelings and sensations because we're now so reliant on a device that we fail to register something doesn't feel right? Because there's an art in that as well, and there's a beauty in that connection as well, and an instinct and a cultivation of that connectedness. And so it's interesting. I find that with some individuals, it can lead to that hyper focus and may become counterproductive, where we say, okay, let's take a break, or maybe this is not the right modality for us. Let's explore something different, or maybe we'll just do it at certain intervals. For other individuals, it's like the insights and the changes they can make can be very empowering. And then for others that I've observed as well is, with HRV, because so much of HRV is driven by our genetics, there is a component that's driven by, okay, how much are we in sympathetic overdrive versus parasympathetic, quality of sleep, all these other metrics, right? Our general health. But then there's the genetic component too. And sometimes it can be really discouraging for people to see their HRV in the lower end of range. And they're like, but I'm doing everything right. And so then it's the conversation about, okay, well, this is where your baseline may be. Let's continue. Don't be discouraged, but know that this is your normal. So then if you dip from that, then we know, okay, something's going on. And maybe over time we can get it up a little bit, but let's not get too discouraged and say, okay, well, all the habits go out the window. So I think that it's interesting. We're still kind of exploring how we interact with this data, and it might be different for different personality types and so forth.
Yeah. You're right. And I think it is something to watch. But I think there is, I've seen on the whole some really powerful kind of health tweaks that have been made that are then sustained because women are suddenly, much more than if I just said, I don't think you should be eating this, or maybe think about eating this instead, or maybe doing this exercise. And actually the changes they see on the data is, and they express it very clearly. And as a result, it's stuff that then feeds through to the family as well. Like, I think this is the beauty of it. It could be done in an isolated way, but then it actually feeds through to their behaviors that then impact on so many other people around them. And yes, sure, there's a genetic component to stuff. But we do know also a lot of our lifestyle is going to be impacting on our health. The stats are about 80% of our health outcomes are going to be lifestyle related. So
exactly.
If that can be sort of driven and navigated with wearables, then fantastic. But like you say, I'm yet to find one device that does it all. And I think just explaining that, and being really cognizant of that when you're looking at your own data, it is useful, and not getting, there's one of my patients who cannot sleep, according to her app, for more than 10 minutes in the night. She has of REM sleep. And but do you know what? So in the beginning, she was like, no, I don't believe it. But then actually she started to make changes because she's, quite competitive, obviously, with herself. And she then started to cut out the alcohol. She started to, no devices, all the things that she needed to do. And slowly she's actually built it up to 20 minutes, which actually for her is really significant, because I think that's the point, is she feels so much better in the morning when she's had 20 minutes of REM versus the 10 minutes. But for her, for me, 20 minutes of REM would be disastrous. But, for her, that's actually a significant health change. So absolutely, I think whatever you're using, tying it into how you feel, trusting your body again, giving yourself full permission to feel the things, and, is going to drive much stronger health changes than just being told by an app that actually your numbers are fine, or not fine. So yeah, I think there's a balance.
Exactly. Yeah. And sometimes too, just comparing where you are now compared to where you were before, not necessarily competing against other people, but just against yourself. What's the best version of myself that I can be? And it can be helpful, definitely, to be guided through different apps on that. So let's go back to, I know we wanted to address the later stages of perimenopause and how they then segue into menopause. So when we talk about those later stages, rather than having the wildly fluctuating estrogen levels, now we start to see that there's a more consistent dip. As you said, by definition, menopause is 12 months without a period. So the late stages of perimenopause, a woman may not have her period, or it still may be irregular, but certainly there's less and less ovulation, estrogen levels are down. So now some new symptoms start to show up that are more consistent with this estrogen loss. And meanwhile, progesterone is still down. So now we've got both of these hormones that are down. And one distinction that I really wanted to make, we talk about estrogen and progesterone as sex hormones, right? But they're so much more than reproductive hormones. And as you've alluded to, there are components of progesterone that are neuroprotective, that are components of estrogen that are also neuroprotective, but also can be neurotoxic depending on the context. There are components of these hormones that affect our metabolism. So they do so much more for our body than just the reproductive system. So I really wanted to stress that because again, this kind of goes into the comprehensive understanding of how do we assess and how do we treat symptoms of menopause in the most natural, compassionate, personalized way, right? So let's talk a little bit about some of those changes that then start to occur and symptoms that you see most often in your patients in that stage.
So I think for many of my patients, this later stage is very much hallmarked by a bit more stability mentally, but they will start to feel achy. And it's when they kind of go, Mayoni, I feel really old. I just feel old, and they may start to show signs on their skin. There may be a sudden increase in fine lines and wrinkles. It may be their hair starts to grey, that they start to notice laxity in all of its forms. They may notice vaginal changes. So they start to report that they may have some soreness or dryness, and it's a very that's a very common thing. And, they're kind of like, I don't want to have sex. It's really uncomfortable. They may have recurrent urinary tract infections. They may notice, which I think is interesting, is suddenly they're going to the toilet for a wee in the middle of the night. They need to pee like suddenly 2 or 3 times, or, they're suddenly waking up to go to the toilet because they're losing that protection of estrogen on the pelvic floor. So actually that kind of, these are the women that I was seeing, right, in my clinics. These are women who then start to lose the protection of estrogen on all of the musculature and the collagen that's supporting, creating the supporting structures, that hammock that lifts up our rectum, our bladder, and the vagina as it passes through the pelvic floor. You then start to notice the symptoms. So they may start to notice, like I say, bladder symptoms. They may notice even evacuatory difficulties. So they may start to say, I'm sitting on the toilet, I know I need to go, but I can't push it out. Because again, that the efficiency of the musculature has started to drop off. And another common symptom is hot flashes. It's that sort of, they may start to notice this, absolutely inexplicable kind of sudden heat and sweating, which again, women are often told to just get on with. And I would encourage women to go and ask again, actually, because we know there's a very strong correlation between hot flushes and cardiovascular disease. And this is, again, not to alarm anyone, but, there is essentially lots of Well, I mean, hot flashes happen essentially because the thermostat in our brain, which normally keeps our body temperature at a really, critical set point, there's very little fluctuation. But as we start to go through the menopause, our brain essentially gets a bit confused and that set point starts to change. And we can then we then start to actually trigger sweating behaviors, cooling mechanisms, because our brain is getting it wrong, is getting that thermostat wrong. One of the things we know definitely heightens that response is exposure to cortisol and adrenaline. We think it probably primes the blood vessels and makes them very responsive. So you have this combination of a thermostat that's not quite working, and then your tubing, your hot water piping system is now not working either. So you then sweating and having hot flashes. But at a slightly more kind of, I'd say, critical level, you're changing the endothelium. We believe that there is then changes at a cardiovascular blood vessel level to the structures, and this then puts us at higher risk of heart diseases and strokes. So a really, really important reason to not just put up with your hot flushes, not just because of the fact it's horrendous and will often disrupt sleep, but it actually has a strong correlation for our future health. Yeah.
Yes, absolutely. Absolutely. And with respect to then transitioning, right, from late stages of perimenopause, which essentially include the same host of symptoms as when one enters menopause. The main difference being that, okay, after menopause, no cycles for a year and no cycles moving forward. If there is any kind of vaginal bleeding, of course, we tell our patients, make sure you see your GYN. That's abnormal, right? But in terms of then approach to management, I mean, and I'm curious to hear your thoughts on this as well. Generally, the symptoms can be very similar. One thing with perimenopause is that if the woman is still cycling, they may have cyclical hot flashes, and so it may not be as consistent. Whereas with menopause, it can be much more consistent. But I'm curious to hear any sort of differences in your approach in those late stages of perimenopause versus menopause, and your general approach to, you've just listed that there are many downsides to not supporting a woman with hormone replacement therapy because of these cardiovascular disease risks and some of the other certainly neuroprotective risks, which I know we'll get into in a later discussion at another time. But tell me a little bit about kind of what your general approach is, what your general threshold is for recommending HRT, and then how long do you typically treat for, and when do you usually start to taper off?
Okay, great. So yeah, I think for me, if a woman is showing signs of needing support hormonally, I will always have that conversation with her. And I think it's important to empower her with that choice, and to give her the facts, because I do really think that women are generally shortchanged with the ability to make an informed decision. We're not given all the information in a way that makes it possible for us to make a decision. So it may be that we're kind of, like I say, gaslighted. We're told that these symptoms are not related. It may be that actually we're told that, oh my goodness, this HRT is awful, it's going to give us cancer. Look at the WHI study, and I think there's a real lack mentality around HRT, which is something that I know you and I are both trying to change. So having a very honest conversation around it is important. There is nothing to be scared of, okay? And I think even in women who've had breast cancer, I will have a conversation with them, as long as they've obviously got to a certain point in their journey, about topical estrogen on the vaginal area, around the vulva, because I think there is so much to be gained. These women are suffering with vaginal dryness that can cause awful symptoms, lichen sclerosis, lichen planus. They're going to get recurrent urinary tract infections. These are significant quality of life disturbing diseases that warrant support. They may also want to have sexual intercourse with their partners and have intimacy. They may well be into a second, third new relationship. I think this is another thing, the longevity conversation brings up so many interesting things, in that women in their 60s and 70s are not the women who were in their 60s and 70s when I was a girl, and that's great. Like, the Golden Girls were in their 50s. Can you believe it? Like, that's actually the age that they were meant to be. And I don't know any 50-year-olds in my world who look and behave like them. So having sex is totally on the cards, and having comfortable, pleasurable sex, I think, is possibly one of those next level of empowerment conversations for women to have. It's like a real women's right to have pleasurable sex and not be ostracized or be made to feel anything other than it's their right to be pleasured and to have sex. So I think supporting them with that, using various lubricants is powerful here, and allowing them to open those conversations up with their partner, and actually giving them the tools to have those conversations, I think, is important. So sexual health is a big piece, isn't it? Because often by this point, their children may well have left home. They may actually be able to finally have sex again without being worried about anyone discovering them. And like I say, new relationships may be happening. So I think sexual health is an important area to discuss with them. And certainly, if we're talking about the pelvic floor and the impact on prolapse, that loss of estrogen, women need to know that there is something that can happen. And actually, using HRT will often, I have found, help women who are having these recurrent UTIs, recurrent, trips to the toilet in the middle of the night, which is disrupting their sleep. It makes a huge difference to their quality of life. So absolutely important to have these chats, I think.
Yeah, absolutely. And I agree with you. I think that the conversation about sexual health and urinary health are, again, some that we don't hear as often when we talk about this. So I think that's very important. And recognizing, as you said, there are different formulations. If somebody is a breast cancer survivor, that possibly, again, depending on various factors, topical estrogen may be an option. And of course, I always recommend discussion with their oncologist, making sure that everybody's on the same page, that the risk is understood. But and then there are other options as well, as you said, for lubrication that are non-hormonal. So there are many, many options. And then we also have, for women that may have an absolute contraindication to HRT, when it just comes to symptoms of hot flashes. I don't know if you have this medication yet approved in the UK, but BOJANA is a medication that exactly acts on that thermostat that just came out in 2023 in the US, that we do use for people with breast cancer or history of breast cancer where HRT may not be an option for them, that can be quite effective. And so I think that just knowing that there are many more options out there, and it's important to be aware of them, and just to be aware of that, okay, risk versus benefit, and everybody may have a different comfort zone there, but it's important to get the facts as much as they're available. Of course, there, as you said, we learn from studies. Many studies have flaws, so we take everything with a grain of salt. But at least using the information that we have to have those conversations with the patients, and then ultimately they make the decision in what makes the most sense for them.
Yeah, absolutely. And I think, the other useful hormones at this point that I think women find beneficial to add in topically is, again, testosterone and DHEA. It can really help with that kind of resilience, that muscle work, building tone. And really, just to go back to that longevity point, we know the things that make a difference to our longevity as women is grip strength and the ability to get up unaided. So that is all, muscle and bone strength. So the more we can do to support women with that, I think, is critical. So using those hormones topically are also important conversations to have at this point. And also, just one other thing to add in is that if women are having recurrent UTIs, I would always want to know what's going on in the microbiome of the bladder and also of the vagina. So, although we've talked about HRT, I think both of us are of the school of thought that there is lots of other things that need support. And it may well be, if HRT is still not an option for you, then it may be addressing the microbiome that sits. So this is that kind of lovely kind of structure, this ecosystem that lives within us, on us, in, all over us. That essentially is sitting in symbiosis with us. And we have got bacteria, viruses and fungi that sit lining our mucosal membranes, including our bladder, our vagina, and of course our colon, our mouth, our skin, that act to protect and do so many other vital functions. So we can look at that in the bladder in women who are having recurrent urinary tract infections. It doesn't have to just be a hormone conversation, but these organisms love estrogen as well. So it's a very kind of, again, a symbiotic process. So yeah, it's important to look at the whole person.
I agree with you completely. And I know we're not diving deep into any kind of lab work, but here it's so important too to consider stool testing and comprehensive stool testing that can give us a clue whether there are increased levels of an enzyme called beta-glucuronidase that recycles our estrogen. And so for women that are not yet in menopause, that might still be dealing with those fluctuating estrogen levels, or what we mentioned previously, estrogen dominance, it can be really helpful to gain insights through some additional testing, whether it be blood work, urine testing, such as the Dutch test, or even stool testing to assess, am I recycling this estrogen that's been nicely packaged up for excretion, and now my body is recycling and bringing it back in through the intestines because of increased levels of this enzyme that's produced by bacteria. So I agree. Of course, having both of us having been trained in functional medicine, one of the pillars of functional medicine is understanding the gut and assessing the gut microbiome and the importance of gut wall integrity, gut microbiome, and inflammation that may stem from that. And while that's not focus of this conversation, that certainly can make a huge impact into all of the areas that we've talked about, such as metabolism, inflammation, some of the symptoms that are associated with perimenopause and menopause, but some of which can also occur independently of that, right?
Sure. And I think, we could sit and talk for hours on this, but absolutely, the estrobolome is fascinating. This is exactly as you described. It's this collection of very specifically targeted microbiome that sits in the large bowel and that is responsible for this upcycling and recycling process. And it's really simply, we need to have really good, effective bowel movements. Otherwise, this detox pathway doesn't happen. And it's, we've got to optimize. So if you are sitting in a state of estrogen dominance, it's about optimizing all the places where we would be breaking down estrogen. Okay. And so optimizing your liver health, optimizing the way that bile is flowing through into your large bowel, optimizing this estrobolome collection, making sure you're having efficient poos, basically. It's really simple. And then optimizing the way that the kidneys are functioning and excreting too. So multi-system, it's why we love it, right? It's just so all-encompassing. But if it feels overwhelming for people listening, and I think I always say this to my patients, is like, do not feel overwhelmed, because it's what is beautiful about the fact it's all connected is that it is all connected. So you can make one small change, as simple as having a really effective bowel movement daily. Brilliant. Like, that will have in its own right a massive impact on so many other processes. So don't ever feel like it's just not worth it. It's just, there's no point, because, there's always a point. We are kind of the sum of all those little 1%. So, don't ever just sort of give up on yourself, I think is a really good thing to remember.
I agree with you completely. And just the the importance of making those even micro changes and micro habits. If the one takeaway is like, okay, I need to eat more fiber so I can have better bowel movements, that's also going to improve the metabolic picture. It may also improve blood glucose. It may improve lipids. Detoxification, certainly. So there are so many, as you said, so many benefits from just that one intervention. Or, okay, I'm going to implement exercise that's going to help with the nervous system. It's going to help with mental health and emotional health, but it's also going to help reduce the risk of Alzheimer's because you're exercising more regularly. So it's like there are all these different things that are affected. We really could go on and on. I know we didn't get a chance to really address supplements in great detail, but I think that might be something that we leave for next time. I wonder if you have any takeaways that you wanted to share that I haven't asked you, or anything that you wanted to conclude with.
No, I think really maybe just extending that kind of message about taking one, doing that small thing. And I think for women who are already on a health journey, who may have kind of feel like they've fallen off the wagon slightly, or something big has happened outside, like they may have lost a loved one, they may have had a kind of a load of work given to them, from the office. Things happen, life happens around you. What we're talking about is building resilience. We've talked about lots of data and numbers, but essentially all of this is about giving you the capacity to be the best you can be. So if you are feeling overwhelmed, narrow it right down. Don't feel like you've got to do all those things for your own health as well every day. On those times when there's a lot going on, really focus on your nutrition, focus on sleep, and focus on movement. I would say those three core pillars will get you through that really tough time. Then you can start to go, oh, right, what about those toxins that I've got in my life? That's not, when you're super stressed, worrying about your toxicity is probably not the right time to add that load to you. But focusing on the key things that have got multiple touch points will help you really navigate that time of stress.
I agree. I really agree. And I think that really starting with habits that are realistic and that we are ready and excited to embark on. And then many other things can follow from there. Like a lot of things can fall from that, can follow that keystone habit and that keystone habit change. Thank you so much, Mayoni. This was such a pleasure. And I really hope that we get to meet again and do more of these talks, because I know we have more topics that we wanted to go through.
Yes, I really look forward to it.